I'm Dr. Fakir Raveri, and this is nosocomial pneumonia in adults. The first learning objective is given a patient with hospital-acquired or ventilator-associated pneumonia, design appropriate empiric therapy. At this point, you should know that community-acquired pneumonia is relatively less severe type of pneumonia caused by less resistant pathogens such as strep pneumo, H. flu, Moraxella catarrhalis, and atypical organisms. When we look at the ventilator-associated pneumonia, it's relatively a more severe disease with mortality as high as 30%, and is typically caused by more resistant pathogens. So the organisms that you want to target empirically are Staphylococcus aureus, which could include methicillin susceptible Staphylococcus aureus or methicillin resistant Staphylococcus aureus, as well as gram-negatives such as Pseudomonas aeruginosa, Klebsiella pneumoniae, and Acinetobacter species. And these organisms are usually more likely to be drug resistant. Because VAP is caused by drug resistant organism, it is extremely important to be aware of drug resistant variations. These variations in resistant patterns can occur at country level, so different countries have different patterns. Within regions, so different cities or different parts of a large city may have different patterns, as well as hospitals. Different hospitals can have different patterns of resistance. Even within a single institution or single hospital, different ICUs can have different resistant patterns. And of course, another thing that's important to know is the source of specimen. For example, if we have organisms from the urine versus organisms from the pulmonary specimen, they can have different resistant patterns. And that's why it's recommended that all hospitals regularly generate and disseminate local antibiogram, ideally one that's specific to their ICU populations if possible. And it's recommended that hospitals do this at least once a year. Now, one key recommendation from the guideline is that while we want to empirically cover for Staphylococcus aureus, if based on the local resistant patterns, it's unlikely to be, Staphylococcus aureus that's MRSA, it's probably okay to just cover for MSSA instead of MRSA. Now, in real world, I haven't really seen any physicians that would not cover MRSA in patients with VAP, but the guideline is making a point that if based on resistant patterns is unlikely to be MRSA, it's probably okay to only target MSSA. And there are some agents that cover Pseudomonas as well as MSSA. So piperacillin, tazobactam, and cefepime, for example, cover Pseudomonas as well as MSSA. And while they do not cover MRSA, if based on local resistant patterns, we think that it's unlikely to have VAP due to MRSA, it will be okay to use them. Now, who exactly needs to receive empiric coverage for MRSA? Generally speaking, both MRSA and Pseudomonas are organisms that originate from the healthcare settings. So patients who have received prior IV antibiotic in the past 3 months or 90 days need to receive one agent that has coverage for MRSA, so typically vancomycin. Also, patients with VAP who are being treated in the ICUs where the prevalence of MRSA is more than 10 to 20%, or if the prevalence of MRSA is not known, these patients need to receive one agent that is active for MRSA. Now, the same is true for Pseudomonas when it comes to IV antibiotic treatment in the past 90 days. Now, with Pseudomonas, it's recommended to use 2 agents that are active against Pseudomonas empirically. Especially in ICUs where when the susceptibility rate of Pseudomonas to the agents that we're using are less than 90%. In other words, the resistance rate is more than 10%. Or if the rate of susceptibility on the antibiogram is not available, or if the patient has a structural lung disease such as cystic fibrosis. So these patients need to receive 2 agents that are active against Pseudomonas empirically until we get susceptibility results back. Now, if we are in a ICU where the susceptibility rate for a specific agent is more than 90%, in other words, the rate of resistance is less than 10%, then a single agent is sufficient. Now, keep in mind that most anti-pseudomonal antibiotics, with the exception of delafloxacin, do not cover MRSA. So when we use two agents that are active against Pseudomonas, we typically end up adding a third agent for coverage of MRSA. So typically vancomycin. And the reason the guideline recommends two agents active against Pseudomonas for empiric therapy is that in case one of the agents doesn't cover the Pseudomonas, the other one should cover it. And this is not for every patient. These are patients that are at risk of having multi-drug resistant Pseudomonas. And of course, once a pathogen has been identified and susceptibilities are known, there is no reason to continue combination therapy. Now, your MRSA coverage antibiotics are typically vancomycin and linezolid. It's important to not use daptomycin, so you should avoid daptomycin because it's inactivated by surfactant. Now, alternatively, ceftaroline is also available should the patient be unable to take vancomycin or linezolid. But the evidence is with vancomycin and linezolid. Now, for the two agents that we use for Pseudomonas, one should be a beta-lactam, and then a second one should be a non-beta-lactam. So the beta-lactams that we choose are piperacillin tazobactam, cefepime, ceftazidime, imipenem, meropenem, or aztreonam. And non-beta-lactam would be ciprofloxacin, levofloxacin, amikacin, gentamicin, tobramycin. Now, we also have polymyxins like colistin and polymyxin B that are usually reserved as last line. So let's say if someone has received IV antibiotic in the last 90 days, so let's say somebody received ceftriaxone 2 weeks ago and now they have ventilator-associated pneumonia, we can choose an MRSA active agent like vancomycin plus one agent from beta-lactam that's active against Pseudomonas. So we can use piperacillin tazobactam, for example, and plus a second agent, so ciprofloxacin. So the patient will end up receiving three agents. So ciprofloxacin plus piperacillin tazobactam plus vancomycin. It is extremely important not to use aminoglycosides as monotherapy. So if you were to use gentamicin, for example, it has to be in combination with one of these beta-lactams. Because there has been, in the studies that we have with aminoglycoside monotherapy, the rate of mortality was higher. Now that we know how to treat ventilator-associated pneumonia, let's take a look at treatment of HAP. So for the most part, we follow the same principles. Majority of evidence is with WAP. So we have fewer studies with hospital acquired pneumonia. So majority of these recommendations are derived from WAP. So I let you, so you can see that, IV antibiotic in the past 90 days is still driving most of these recommendations. And you can see that we use the same antibiotics. So if someone has HAP and is not at risk for mortality and no risk factors for MRSA, they can receive a single one of these agents. So these agents will cover Pseudomonas as well as MSSA. Whereas if someone is at risk for MRSA, but not at risk for mortality, they can receive one of these agents for Pseudomonas, plus either vancomycin or linezolid to cover for MRSA. And of course, if someone is at high risk for mortality, then that patient should receive two agents for Pseudomonas plus one agent for vancomycin. So one of the beta-lactams plus one of the non-beta-lactams active against Pseudomonas plus an agent for MRSA. We designed appropriate empiric therapy for HAP and VAP. Now, given microbiological results, let's de-escalate from empiric therapy to pathogen-directed therapy. In general, there are a lot of different types of bacteria, and they could be part of the normal flora, so they are actually essential for the normal human health, or they could be colonized, which means that bacteria that are not part of the flora could actually be in part of like the GI tract, for example, and not necessarily cause an infection and just colonize it. Now, whether colonized or as part of normal flora, bacteria occasionally can have resistant genes. So let's say the red bacteria here are resistant to antibiotics and the blue ones are susceptible. And keep in mind that this is just part of the flora, not necessarily an infection. Now what happens every time that we use antibiotics is that the antibiotic, while we use it to treat an infection, what it does to the actual flora is that it actually wipes out all the ones that are susceptible to that antibiotic, and the ones that are resistant to that antibiotic will stay behind because the antibiotic could not kill it. Now again, those bacteria were not really causing an infection, they were just part of the flora. But when we use the antibiotic, we actually selected for them, and now they have the opportunity to become the dominant bacteria in the flora. Or if they were just a colonization, now they become the dominant organisms in the body. And keep in mind that they all have the genes for resistance to antibiotics. Now, occasionally, if someone gets actually infected, what happens is that these bacteria that have the genes, the resistant gene, they can actually transfer it. So they can donate that gene to a pathogen, which will cause drug-resistant infection. This whole process is referred to as selection pressure. Which brings us to the concept of broad versus narrow spectrum of activity. So generally speaking, broader antibiotics are more likely to cause selective pressure because they can wipe out more clinically significant organisms and leaving behind the resistant organisms. Now, when it comes to broad versus narrow, the generally accepted definition is based on gram-negative coverage. It's not so much about a head count, so it's not about how many organisms an antibiotic covers. It's more about which organisms does it cover. So it's about clinically significant organisms. So in order to understand if a drug is broad or narrow, you should ask yourself the following question. Does it cover carbapenem-resistant Enterobacteriaceae? Now, CRE, such as E. coli and Klebsiella, that are resistant to carbapenems, we don't have a lot of antibiotic options for them. So this is one of the most resistant pathogens available. So if we have antibiotics that's active against CRE, we should reserve it for CRE. So this is considered the broadest class of antibiotics. The next question you should ask yourself is, does the antibiotic cover multi-drug resistant Pseudomonas? If so, it is very broad and it should be reserved for multi-drug resistant Pseudomonas. Another question to ask is, does it cover Pseudomonas period? Because Pseudomonas can select for resistance very quickly, if you are not treating Pseudomonas, you should not be using a drug that's active against Pseudomonas if possible. And the next question is, if a drug covers ESBL Enterobacteriaceae, it should be reserved for ESBL organisms if possible. And lastly, if a drug is more likely to disturb the gut flora and lead to Clostridioides difficile infection, we should use an alternative if possible. Here's a pyramid to help us compare broad and narrow spectrum of activity of antibiotics. So the higher you are on the pyramid, the narrower the spectrum of activity, and the lower you are on the pyramid, the broader the spectrum of activity. Now I have created a tiering system, so tier 1, 2, 3, 4, 5, 6 doesn't really exist. I just created this to help us understand and compare different antibiotics when it comes to broad versus narrow. So in tier 1, I would place cefazolin, which is a first generation cephalosporin, and trimsulfa and amoxicillin. And that's because when it comes to gram-negative spectrum of activity, these agents have limited activity, limited to protease, E. coli, and Klebsiella species. Now, these organisms can still develop resistance to this, but in general, the activity of these agents are limited to wild type P, E, and K. Now, in tier 2, I would place drugs like ceftriaxone, which is a third generation cephalosporin, and ampicillin sulbactam, which has expanded activity when compared to amoxicillin. And in addition to protease, E. coli, and Klebsiella, these agents are also more likely to cover Haemophilus and Neisseria species. Now in tier 3, I will place ertapenem and gentamicin. Ertapenem is the only carbapenem that does not have activity against Pseudomonas, so therefore it is in tier 3 because these agents do not have activity against Pseudomonas. Now, as of 2023, gentamicin is no longer considered active against Pseudomonas, and that is based to updated review of its PK/PD characteristics. So with the safe doses that we use in patients and with the current MIC in Pseudomonas species, gentamicin is not likely to cover Pseudomonas. So for that reason, it has been placed in tier 3, and these agents do not have activity against Pseudomonas, but they are active against ESBL, so that gives them the advantage over tier 2. So if you have Enterobacterales that are producing ESBL, they will essentially be resistant to the drugs beta-lactams in tier 1 and 2. So ertapenem will be drug of choice for ESBL producing Enterobacterales for severe infections such as bacteremia. And gentamicin, of course, is not affected by ESBL since it's an aminoglycoside. And both of these agents also have extended activity against more gram-negative organisms. So Citrobacter, Providentia, Enterobacter, and Serratia. And they do not have activity against Acinetobacter. Now, when it comes to tier 4, this is when we really start to define broad spectrum because of activity against Pseudomonas. So essentially, this is where most experts would agree, where we draw the line between broad and narrow, because Pseudomonas species can develop resistance relatively easier compared to other organisms. So if you are not suspecting Pseudomonas when you're treating an infection empirically, we shouldn't use an agent that's active against Pseudomonas when we have multiple options. So this is literally the beginning of broad spectrum, and these are drugs that are pretty much active against wild type Pseudomonas aeruginosa. So ciprofloxacin, levofloxacin, tobramycin, cefepime, ceftazidime, and piperacillin tazobactam are the most common ones. And I say wild type because, again, Pseudomonas can develop resistance to these agents, but wild type essentially, where these agents will have intrinsic activity against Pseudomonas. And that's why we have a tier 5. These are agents such as the rest of carbapenems. So remember, ertapenem doesn't have activity against Pseudomonas, but the rest of carbapenems do. And also ceftolozane tazobactam. Ceftolozane tazobactam was specifically designed to be having potent activity against multi-drug resistant Pseudomonas. So when Pseudomonas is resistant to drugs in tier 4, that's when these drugs come in. So, we don't really want to use these for all Pseudomonas. We really want to reserve them for when Pseudomonas turns into multi-drug resistant Pseudomonas. So for that reason, these are typically reserved or restricted in hospitals, and they will require approval for use just to make sure that the ID or antimicrobial stewardship team can get a second look and make sure that their use is appropriate, because the more we use these agents, the more likely that we will lose them to resistance. So we really want to use them judiciously. And then tier 6, they are still active against multi-resistant Pseudomonas, but in addition, they also have activity against carbapenem-resistant Enterobacterales. So some Enterobacterales, of course, can develop ESBL, but the smaller portion of them can also develop resistance to carbapenems. So if, we have E. coli resistant to meropenem, for example, that's when we want to go to tier 6. So these are really reserved for when we have these difficult to treat organisms. So cefiderocol, ceftazidime, avibactam, and some of these carbapenems combined with beta-lactamase inhibitors. So meropenem, vaborbactam, imipenem, relibactam, and also some other classes. So polymyxins, so polymyxin B and colistin, as well as plazomycin, which is an aminoglycoside, the most recent aminoglycoside, has good activity against these agents. They also have a tier 6B because there are agents that are active against CRE and ESBL, but they actually do not have activity against Pseudomonas. So there are actually a hole in tier 6B, but still these are pretty broad, even though they don't have activity against Pseudomonas, because they are active against CRE. So we really want to reserve these for when we don't have other agents available, because when we get infections due to CRE, we really have limited options. And by the time we get to CRE, it's really easy for these organisms to be resistant to multiple classes of antibiotics. So tigecycline, eravacycline, and amikacin, these are they may have activity against CRE, but they don't have activity against Pseudomonas. So amikacin, just like gentamicin, as of 2023, is no longer considered active against amikacin for systemic infections, based on its updated review of PK/PD characteristics. The only time that it will be okay to use amikacin for Pseudomonas is if it's in urinary tract infections, and that is because a high concentration of amikacin can be achieved in the urine, and that can meet the PK/PD parameters. But outside of the urine, pretty much based on current circulating organisms, MIC, amikacin is no longer considered active against Pseudomonas for invasive infections. One thing I want to mention about Acinetobacter. Acinetobacter is also an organism that can easily develop resistance to multiple classes of antibiotics. So I mentioned that tier 3 doesn't have activity against Acinetobacter. Now in tier 4, it is depending on the agent, it may or may not have activity against Acinetobacter. And even at tier 5 and 6, even though I have A here in case for Acinetobacter, you really need to check for susceptibility, because Acinetobacter may or may not be resistant to these agents, because again, it's really easy for Acinetobacter to develop resistance to multiple classes of antibiotics. So when it comes to gram-positive, we discussed the risk factors for MRSA. So empirically, you will have an agent like vancomycin or linezolid for MRSA, and once the culture and susceptibility results come back, and if it is MRSA, then we continue vancomycin, and then you can discontinue the antibiotics for pseudomonal coverage. Alternatively, if the results come back and it is not MRSA and it is MSSA, then you should discontinue vancomycin and start the patient on oxacillin or nafcillin or cefazolin, because these are tier 1. These are tier 1 or antibiotics, and you should discontinue any other agent for Pseudomonas. Now, if the patient actually happens to have Pseudomonas, then you should use the results of antimicrobial susceptibility to see which one is susceptible and use it. Now, generally speaking, only one agent is sufficient when it comes to pathogen-directed therapy. Occasionally, you can use 2 agents if the risk of death is high in the patient. For example, septic shock would be an example. So if a patient is still in the ICU on pressors, in order to maintain normal blood pressure, that patient could benefit from 2 agents, even for definitive therapy. Again, it's important to avoid aminoglycoside monotherapy. Even if Pseudomonas is susceptible to aminoglycoside, you should not use aminoglycoside monotherapy. You can only use aminoglycoside as a part of a combination. So, for example, you can use aminoglycoside plus cefepime. Now, when it comes to multi-drug resistant pathogens, you can also add inhaled therapy. So one of the problems is penetration to the lung. So if it's difficult for many of these antibodies to actually get to the site of infection, so inhaled therapy will actually deliver the antibiotics to the site of infection, which is the lung. But inhaled therapy should never be monotherapy. It's always an add-on. So you add it to your IV therapy. So if someone is getting cefepime and IV tobramycin, and you can add inhaled tobramycin on top of it. So inhaled tobramycin is not to replace IV tobramycin. And lastly, if you do have an ESBL agent in the lungs, the guideline doesn't make a specific recommendation, so you can use anything that's susceptible. Now, historically, we have said that carbapenems are drug of choice for ESBLs, and it has been subject to some controversy in recent time. Recently, there was a study, the Merino study, that showed that when it comes to bacteremia, carbapenems are better than piperacillin and tazobactam because it reduces mortality. So my recommendation is to also use carbapenems for pneumonia. But basically, we have limited data when it comes to pneumonia with ESBLs. We designed appropriate empiric therapy for HAP and VAP, and we de-escalated from empiric therapy to pathogen-directed therapy. Now let's evaluate a patient's clinical stability to determine if antibiotic therapy can be switched from IV to PO. Now, IDSA guidelines for community-acquired pneumonia gives us some guidance for switching patients from IV to PO. Now, keep in mind that community-acquired pneumonia can be treated as outpatient in moderate or less severe patients, whereas in hospital patients, the patient will receive IV antibiotics. So based on IDSA, patients who are hemodynamically stable and clinically improving can be switched from IV to PO as long as they are able to tolerate oral therapy. Another thing to consider is to make sure that the GI tract is also functional. And we can apply some of these principles to patients with nosocomial pneumonia. Now, the reason we want to switch patients from IV to PO as soon as possible, when they can tolerate it, is, first of all, to make sure that we don't introduce any, line infections, as well as getting patients ready to be discharged. However, keep in mind that the guidelines do say that inpatient observation while receiving oral therapy is not necessary. So if the patient is ready to be discharged from the hospital and they're on IV antibiotics, and it's okay to discharge them and send them home with oral antibiotics. It's not necessarily to keep them one extra day to make sure that they tolerate the oral antibiotics. Now, there was a systematic review published in JAMA in 2016 that looked at the evidence for, criteria helping transition patients from IV to PO. So basically, absence of mental confusion, ability to take oral medications, absence of fever, hemodynamic stability, which is defined as heart rate less than 100, and of course, systolic blood pressure greater than 90. This is without using pressors. So, without using norepinephrine, the blood pressure should be greater than 90. Another criteria is respiratory rate lower than 25 and oxygen saturation higher than 90%. And of course, we have to make sure that the patient is clinically improving before we change from IV to PO. And sometimes the patient may not be improving, and there could be different reasons for it. One reason, of course, could be that we have identified the correct organism, or empirically we are targeting the right organism, but we use the inappropriate antibiotic, or we were using the wrong dose. So it's important to target the right organisms, use the right antibiotics, and also use the right dose. So we have to make sure that the dosing is appropriate based on body weight, based on renal function, based on hepatic function, and based on drug disease, and drug-food interaction. So as pharmacists, we have to take all of those considerations to make sure that the patient is receiving the right dose. And along with the dose also goes the right frequency. The frequency is also important. Sometimes, the organisms can develop resistance while on treatment. So it's, another thing to consider if the patient is on the right drug and on the right dose. You may want to question, whether the organism developed resistance while the patient was on the antibiotics. So sometimes we may send another culture just to make sure that the organism is still susceptible to the antibiotics we're using. I talked about the wrong dose. Sometimes the patient may miss a dose. So let's say the nurse comes to administer the antibiotic and the patient is not available. So whether the patient was sent for imaging or the patient, was not available for any reason, that's important to consider to talk to our nurse colleagues to make sure that the antibiotics were actually administered. Another thing is to make sure that the antibiotics are actually getting to the site of infection. So sometimes, if the organism is in a specific area where antibiotics cannot get, source control becomes really important. So empyema, for example, is an example, when we actually need to make sure we have source control because antibiotics may not be able to get there. So it's important to actually, drain the site of infection. In the case of pneumonia, sometimes the patient may still have like shortness of breath and not seem like they're getting better, and could be due to other reasons that has nothing to do with pneumonia. And of course, we have to target the right organism and use the right empiric therapy to target those organisms. And also we should think of non-infectious causes. If the patient has fever due to, either a clot or cancer, non-infectious causes of fever. Sometimes we may have drug-induced fever. So, beta-lactams, for example, occasionally cause drug fever. And lastly, presence of an unrecognized concurrent infection. So, if you're trying to target pneumonia and suddenly the patient has, bacteremia that led to endocarditis, that could be something that's, could be the reason why the patient is not doing well. And that's important to consider. Given a patient with HAP and VAP, we design appropriate empiric therapy, and given microbiological results, we de-escalated from empiric therapy to pathogen-directed therapy. We also evaluated a patient's clinical stability to determine if antibiotic could be switched from IV to PO. Now, let's recommend an appropriate duration of therapy for HAP or VAP. Now, prior to the 2016 IDSA guideline for HAP and VAP, it was usually the question of whether we should treat for 1 or 2 weeks when it comes to, VAP and HAP patients. And it was primarily due to the NUME study, which was published in JAMA in 2003, which looked at 8 days of treatment versus 15 days of treatment. And what they found was that there was actually no difference in mortality between the two groups, whether the patient received 8 days of treatment or 15 days of treatment. However, when they did subgroup analysis, in the group of patients who had VAP due to non-lactose fermenting organisms such as Pseudomonas and Acinetobacter, there was increased recurrent infection in the group of patients who received 8 days of treatment. And because of that, we started to treat patients who had VAP due to Pseudomonas or Acinetobacter for 14 days. Now, things started to heat up when a Cochrane review in 2015 compared short-term therapy to long-term therapy in patients with HAP and VAP, and found that in a group of patients who actually got short course of antibiotics for, let's say, 7 or 8 days, there was actually increased 28-day antibiotic-free days and reduced recurrent VAP due to multi-drug resistant pathogen. In other words, patients who had longer duration of therapy, they actually had more multi-drug resistant pathogens. In addition, there was no difference in mortality, recurrent pneumonia, treatment failure, or hospital length of stay when you compare the two groups. And they did still find that in group of patients who had Pseudomonas Acinetobacter, short course of antibiotics were associated with recurrent infection, but no other differences. So while these patients had the recurrent infection, those recurrent infections were less likely to be due to multi-drug resistant pathogens. So they were easy to treat. Whereas patients who had longer duration of treatment, while they were less likely to have recurrent infections, those recurrent infections were more likely to be multi-drug resistant. There was also a study published in Chest that showed that short course regimen compared to long course therapy was not associated with any difference in mortality, recurrent pneumonia, ventilator-free days, or duration of mechanical ventilation, or length of ICU. So what happened in 2016 when the IDSA guideline came out is that the panel actually did their own systematic review and meta-analysis, and they found that the specific subpopulation with VAP due to non-glucose fermenting gram-negative organism was analyzed, and no difference was observed for pneumonia recurrence. So here's what the IDSA guideline recommends for length of therapy of VAP. They actually recommend a 7-day course of antimicrobial therapy rather than a longer duration. However, this recommendation is not to replace clinical judgment. So there may be situations in which a shorter or longer duration of antibiotic may be indicated, depending on whether the patient is clinically improving or deteriorating based on radiologic and laboratory parameters. But for most patients, 7 days of antibiotics is likely sufficient. And we can extrapolate from the VAP evidence and make basically the same recommendation for patients with HAP. So also for HAP, the guideline recommends 7-day course of antimicrobial therapy, but this is not to replace clinical judgment. We designed appropriate empiric therapy for HAP and VAP, and we de-escalated from empiric therapy to pathogen-directed therapy. We also evaluated patients' clinical stability to switch from IV to PO and recommended appropriate duration of therapy for HAP and VAP. Now let's develop a patient-specific plan for prevention of pneumonia. When it comes to the prevention of pneumonia, the older 2007 IDSA guidelines has several recommendations. Of course, influenza can lead to secondary bacterial pneumonia, so influenza vaccine is recommended, as well as pneumococcal vaccine, which I will discuss shortly. Now, for patients who are hospitalized, vaccination can actually be performed at discharge prior to patients going home, and of course, it can also happen in the outpatient setting. Smoking is a risk factor for pneumonia, so smoking cessation is very important in preventing community-acquired pneumonia. And those who continue to smoke, influenza and pneumococcal vaccination is really important for them. And of course, respiratory hygiene, including washing hands, is really important in preventing spread of germs. The new 2019 IDSA guidelines did not make any new recommendations for prevention of pneumonia. Now, before we talk about pneumococcal vaccines, it's important to distinguish between pneumococcal disease and meningococcal disease. So when people talk about pneumococcal disease, in general, they are referring to pneumococcal pneumonia or pneumococcal meningitis, which are caused by the organism Streptococcus pneumoniae, which is a gram-positive coccus. Now, this organism Streptococcus pneumoniae does have an outer capsule that's composed of polysaccharides, and because there is variation in this polysaccharide, there are more than 100 serotypes that are known. So the vaccines that we have are targeted at different serotypes. In general, we have two types of pneumococcal vaccines. We have pneumococcal polysaccharide vaccine. So it's literally they have taken the polysaccharides and they have put it in there. So Pneumovax 23 has 23 different serotypes in there. We also have pneumococcal conjugate vaccine. These are vaccines that are conjugated to a protein to improve immunogenicity. And there are currently 4 of them on the market. So PCV13, which targets 13 serotypes, PCV15, PCV20, and PCV21. Now, in contrast, we have meningococcal disease, which essentially means meningococcal meningitis. And this is due to organism Neisseria meningitidis, which is a gram-negative coccus, so it's very different than Streptococcus pneumoniae. And similarly, it has different, because it has a capsule, there are different serogroups. There are 12 serogroups that are known. Worldwide, serogroups A, B, C, W, X, and Y cause invasive disease, whereas in the US is more likely to be serogroup B, C, and Y. And there are different vaccines on the market. So, for example, there are the ones that target serogroup A, C, W, Y. There are some vaccines that target only serogroup B. And more recently, we have vaccine that targets all 5 of these that are most commonly causing disease. So if somebody wanted to prevent the risk or reduce the risk of developing meningitis, essentially because there are 2 organisms that cause meningitis, they need vaccination against Streptococcus pneumoniae, so pneumococcal vaccine, as well as vaccines against Neisseria meningitidis, so meningococcal disease. Now, when we give pneumococcal vaccine to people, So for sure, we are trying to prevent pneumonia, but more importantly, it is also reducing the risk of developing meningitis. So that's something important to keep in mind. In fact, when Streptococcus pneumonia causes invasive disease, typically pneumonia, which can be non-bacteremic for the most part, but some of these can be bacteremic pneumonia. So, when you have bacteremia, it can make it throughout the body, and when it makes it to the brain, you will have meningitis. So these are relatively less common, but certainly more fatal. Now, as of this recording, there are 5 pneumococcal vaccines available on the market. The first one is the Pneumovax 23. So this is targeting 23 different serotypes, and it is approved for age 2 years and older. These are essentially all of them 0.5 ml intramuscular injections, but Pneumovax can also be administered subcutaneously, and they all need to be stored in a fridge. So refrigeration is required, but not freezing. Prevnar 13 targets 13 of these serotypes. Then we have Vaxneuvance, which is PCV 15, Prevnar 20, which is PCV 20, and Capvaxive, which is a PCV 20. Now, with the exception of PCV 21, they're all approved for adults and children. And the PCVs, which are pneumococcal conjugate vaccines, differ from PPSV, which is polysaccharide vaccine. They're essentially conjugated to CRM197 carrier protein. So all 4 of the PCVs are, that's how they are conjugated, and that improves immunogenicity, which I'll explain in a minute. But also another thing to keep in mind that PCV 13, 15, and 20 also have aluminum in them as an adjuvant to further enhance immunogenicity. The latest one that has come to the market, PCV 21, does not have this adjuvant. So that's something to keep in mind, and I'll mention that shortly. Now let's take a look at which serotypes they cover. So you can see that PPSV 23, which is the oldest one, covers 23 different serotypes. And again, keep in mind that there are over 100 different serotypes. So essentially, we're trying to target the ones that are more likely to cause disease. Now, PCV 7, which is no longer on the market, targeted 7 of these that are also included in PPSV 23. In general, the response from PPSV 23 is not great. That's why we are trying to have different PCVs, and it's more difficult to create PCVs because they're conjugated to protein, and proteins are much larger molecules, so they're more difficult to include as many serotypes as possible in a single shot. So over years, we have seen the evolution of these PCV vaccine. So PCV 13, which is still on the market, covers 13 of these. PCV 15 added 2 more to PCV 13, and then PCV 20 added even more to PCV 15. Now, one thing that's interesting, the latest one, which is PCV 21, is not necessarily adding to the previous one. So it has it actually excluded some of the ones that they think are no longer causing disease because of years of vaccination and herd immunity, but they have introduced a bunch of new ones that are causing disease in adults specifically. So the previous ones were specifically targeted at children, whereas PCV 21 is more designed for adults. And here's what I mean. So when you see in this, we're looking at different age groups. So we're looking at what percentage of invasive pneumococcal disease is due to specific serotypes. And the blue is what's included in PCV 20 but not in PCV 21, whereas the gray is included, is common in both PCV 20 and PCV 21, and then orange is included in PCV 21 new and is not in PCV 20. So when you look at this, for example, in adults, you can see that somewhere between 54 to 62% of invasive pneumococcal disease were due to serotypes that were included in PCV 20, But when you look at PCV21, that actually improves it. So somewhere between 77 to 85% of invasive pneumococcal disease cases in adults are actually covered by PCV21. So that's why PCV21 was designed to improve essentially prevention of pneumococcal disease in adults specifically. Now, let's take a look at some of these vaccines. So PPSV23, which is the oldest one on the market, came to the market in 1983. Because it's pneumococcal vaccine, it does not depend on T cells. And because, infants or toddlers under the age of 2 have not matured their immune system, you're essentially not going to have immunogenicity in age under 2 years. So PPSV 23, for that reason, because it does not activate the T cells, it is not used for under age 2. Now, this does cover 23 valents, and essentially the studies have never shown that it can actually reduce the risk of pneumonia, but certainly it can prevent invasive pneumococcal infection, specifically meningitis. So there is certainly value in administering it to people. And then PCV13, which is the better formulation, so it's conjugated, so it has enhanced immunogenicity that depends on T cell, and for that reason it does work in children under the age of 2. So it's approved for anyone 6 weeks old and older. So it's part of, or it has been part of childhood immunization schedule. And it, in fact, it came to the market for children first before it came to the market for adults since 2010. And it has been proven to prevent not only meningitis but also pneumonia. So PCV13 is definitely more valuable than PPSV23, but because it only covers 13 serotypes, they definitely need to be administered in combination, not necessarily at the same time, but I'll go over the schedule shortly. Now, the new pneumococcal vaccines, so PCV 15, 20, and 21, have come to the market in the past few years. So since in 2021, we saw that PCV 15 and 20 came to the market for adults first, followed by approval for children. And PCV 21 currently is only approved for adults. Now, these are essentially come to the market based on immunogenicity data. So we don't have efficacy data for any of these. So in other words, nobody has done studies to show that they can prevent pneumonia or meningitis. What they have done is to show that they can trigger the immune system to have antibody response against these serotypes that are included. So PCV 15, 20, and 21, they all have shown that they can have robust immune response. Now, here's what the CDC recommends when it comes to using these vaccines. So essentially in a healthy person, so person with no comorbidities and person who has not received a PCV vaccine in their life. And I say that because nowadays PCVs are part of childhood immunization, but they didn't always exist. So there are a large portion of the population did not have these vaccines when they were children. But nowadays children are receiving these as part of their childhood immunization. So for people who have not received this as part of their childhood, for ages 19 to 64, for a healthy person, there's really no need for these. Now, once these people turn 65, they do need to get vaccination against pneumococcal disease because of high risk of mortality when it comes to pneumonia and other invasive pneumococcal disease. So they can essentially get any of these PCV, but it's important to get the PCV. So remember, PCVs are more effective than PPSV. So they can get either PCV 15, 20, or 21. So any of them are recommended with no preference over one or another. Now, the caveat is that if the patient did get PCV 15, they do also need to get a PPSV 23, just because 15 is not covering as many serotypes as possible, whereas 20 and 21 cover a large variety of serotypes. And here's the timing. So the timing is because PCVs are more effective, they should always get that first. In the case of 20 and 21, there's no need for PPSV anyway, so that's all they get. So either PCV 20 or 21. However, if the patient did get PCV 15, a year later, they will get a PPSV 23. And it's important to know that PCV and PPSV 20 should not be co-administered at the same time. So there needs to be some time between them. In this case, for healthy persons, at least 1 year. Now, in case somebody had received PPSV 23, again, because PPSV has been on the market since the 80s and these vaccines are relatively new, you could come across people who had previously received PPSV 23 a few years ago, and now they're interested in these new vaccines. So there needs to be at least 1 year apart between PPSV 23, and they can get pretty much any of these. So PCV 15, 20, or 21, with no specifically preference, for one over another. Vaccine doses do not need to be repeated if they were given before age 65. In other words, in healthy persons, they don't need to get vaccinated before age 65. They do after 65. But in case somebody, went ahead and got it, let's say at age 60 or age 55, by the time they turn 65, there's no need to repeat it. As long as they have got this at some point in their life, that's what matters. They will be protected once they turn 65. Now, when PCV 15 is used in those with history of PPSV 23 receipt, it need not be followed by another dose of PPSV 23. So in other words, if somebody had PPSV 23, then got PCV 15 when they turn 65, they're complete. There's no need to wait another year to give another PPSV 23. Now, let's take a look at people who have other conditions. So it's good to think of 3 different groups. The first one is immunocompetent persons who have comorbidities, and that includes alcoholism, which the CDC defines for females having 4 or more drinks on an occasion in the past 30 days, and a drinking occasion is considered to be approximately 2 hours long. And for males having 5 or more drinks on an occasion in the past 30 days. And the next one is chronic heart disease, but not hypertension. So there are things like heart failure, chronic liver disease, such as cirrhosis, chronic lung disease like COPD, cigarette smoking, and diabetes. For these people, prior to age 65, between 19 and 64, it's required for them to receive a PCV vaccine. So is there PCV 15, 20, or 21? And if it's PCV 20 or 21, there's no need for PPSV 23, just like healthy people. But with PCV 15, they do need to get the PPSV 23 a year later. Now, the next 2 groups are more severe conditions. So the first one is CSF leak and cochlear implant, but immunocompetent. And then the third group is immunocompromised persons. So these are people with asplenia, people with cancer, chronic renal disease, HIV infection, immunodeficiencies, sickle cell disease, and solid organ transplant. For these people, it is important for them to get the PCV vaccine prior to age 65. So either PCV 20, 21, or PCV 15. And of course, with PCV 15, they do need to get PPSV 23. What's different with these 2 groups is that because their conditions are more severe, you may consider giving that PPSV 23 sooner. So instead of waiting a year to give that PPSV 23, an 8-week separation can be considered for PCV 15 to give them that extra coverage as soon as possible. And it says it's considered because you might get insurance issues. So this is a matter of whether you can get the insurance to work or not. Now, in case people had previously received PPSV 23, they do need to get their PCV at least 1 year apart in order to get full protection. Now, because PCV 13 has been on the market for the longest time, the question is, what do we do for people who had previously completed their immunization schedule? So specifically for age 65 and older. So they got their PCV 13 and they got their PPSV 23. And these vaccines, the other ones were not available at the time. So they finished what should we do now? So this is essentially a shared clinical decision making. So you can discuss with the patients potential benefits of these vaccines, and if their insurance covers it, for example, or if they're willing to pay out of pocket, they may receive PCV21 or PCV20 at least 5 years after that PPSV23. And PCV15 is not on this because those two extra serotypes is probably not worth the trouble. But PCV20 and 21 give enough additional serotype that they may be considered as part of shared decision making. And for those other patients who have indications for getting the vaccine before age 65, the same. So if they had received PCV13, they may get PCV21 or 20, at least a year later. And for those who had received PCV13 and they completed it with PPSV23, and back in the days, some of these immunocompromised patients actually needed to get 2 PPSV23s after PCV13. So regardless, if they have completed it by the time they turn 65, they can get either PCV21, 20, or get another PPSV23.